This is the enhanced recovery model. Urology uses enhanced recovery to help patients through their pathway after surgery, but the importance of enhanced recovery is that we actually start this prior to patients having surgery. There's this altered way that we manage patients during the surgery process, and then also the recovery afterwards. This has been a process that's been in place for many years, and actually what needs to happen now, this needs to be normal working ways on the wards. We do help you by providing you with pathways. We've got a specific pathway for cystectomies, and we've got a specific pathway for nephrectomies, but there's a lot of aspects of this that overlaps. And this is where Sonia and I will try and talk you through it over the next few minutes to help you. But as I say, please refer back to the booklets, which will give you the direct guidance day to day for the patients. Prior to surgery, patients will come in and they'll either meet me or Sonia. At the moment, we're seeing a lot of patients literally to give them drinks, but then we phone them to give them the information over the phone. When we talk about drinks, we provide you a high carbohydrate drink and 40-sip drinks, which you have over 2 days prior to surgery. We are going to ask you to get more active. This is one Sonia really likes, and she will. We ask you to do 30 minutes of activity 5 times a week. With this activity, it could be something simple as you cleaning your house, but you need to do it continuously for half an hour so that your heart rate's increased, you feel a little bit flushed, and you feel a little bit short of breath. Not so much that you cannot talk to the person who's doing the activity with you. But if you at this stage only had 5 minutes of activity and you then have to stop, then there's no way you're going to get over a 2-week period to half an hour. But if you can build up to 6 minutes, 7 minutes, or even 10 minutes, that means that you've worked and your body is going to do better during surgery. The other thing we ask you to do is make sure that your other comorbidities are managed well. So we ask the patients to go and see their GP to make sure that diabetes is under control, their blood pressure is under control. We also ask patients to stop smoking, if at all possible at this stage, because it will mean that they recover better from anaesthetic post-surgery. It also helps with wound healing post-surgery. We also ask patients to stop drinking, or at least reduce the amount of alcohol that they take in, because this will also help them post-surgery. The other thing we need to look at prior to surgery is a diet. So we want you to eat, or we ask the patients to eat as healthy as possible. When they eat, you ask them to look at vitamins and minerals, so they need to have fruit and veg, but they also need to have proteins, whether or not they get proteins in by having meat and fish and eggs, or whether or not they have vegetable forms of proteins, doesn't matter. But it's very important that that gets sorted prior to coming into surgery, because if your diet is good before surgery, you will repair better after surgery. The other reason we see patients is to explain to them what's actually going to happen during the surgery. So we will talk to them about what drains and tubes they will have, whether or not they will be expected to go home with a catheter in, whether or not they would need to do any specific personal care afterwards, like patients who goes home with a stoma may need to be taught how to look after the stoma. The patients with catheters also would be catheter care, but your new bladder patients may need to learn self-catheterization prior to the procedure. But it also means that we can teach them beforehand how to get in and out of bed. Because by knowing how to get in and out of a bed post-procedure, it makes it a lot more comfortable. But it also gives you ways of doing it, especially at home where you don't have a bed rail that you can hold on to, or you don't have a kind nurse who's going to help you get things. So learn to manage that. Also prepare your house for going home. If you live in Bath and you've got 5 flights of stairs to get to the top, that patient will find it very difficult to do 5 flights of stairs 2-3 times a day to go to the bathroom. So can they have their bed at the same level as the bathroom, or at the same level as the kitchen, so they can manage a bit easier? We ask the family and friends to help the patient to sort this out prior to them actually coming to hospital, rather than it becoming a problem after they've come in.
So if I start with nephrectomy, so post-op, you would encounter either radical, where the whole kidney is removed, partial, where part of the kidney is removed, or a nephrectomy, where the kidney and the urethra are removed. Depending what the patient had, depending what you would normally look after at post-op. The principle for all the 3 is the same. We would like patients to get out of bed as soon as possible the following morning. We will teach them how to get out of bed by rolling on a side, which makes it easier for the patient and less painful in the abdomen. We would like them to sit on the edge of the bed and sit out in a chair if possible. We will encourage the patient to take regular deep breath-ins every hour because we want them to expand their lungs, to stop preventing chest infections, blood clots, and we'll need them to use chewing gum if possible. We would normally advise them to chew gum 3 times a day for 15 minutes in between meals, and this will help the bowel start to go. One of the issues of those 3 operations is that the bowel will go on strike because it's been moved around throughout the surgery, and it might take 3 to 4 days before the bowel starts opening. Also, due to the medication that we give them, such as codeine, tramadol, or Oromorph, that will impact on their constipation levels. So chewing gum is very important, as well as mobilize them as soon as possible to prevent all of these. Regarding catheter care, please have a look at the ward round and what we've asked on a ward round plan, because on an nephrectomy where the kidney and the urethra is removed, we normally get a cystogram 2 to 3 days after the surgery. In some cases can be up to 10 days. So in this case, the patient will need to go home with a catheter care plan, with catheter bags, and then come back to urology outpatients, have a cystogram and have a talk afterwards. The main thing with these operations is get the patient moving and out of bed as soon as possible. They sometimes struggle with pain, and that's just because of where the operation's been done. But as long as we encourage them, give them a towel, which helps them to support the abdomen while they take deep breath-ins and move. And that's the main important thing, really.
The cystectomy pathway is slightly different. We follow a lot of the rules that Sonia's just discussed. So we talk about having chewing gum to help with bowels. But at 3 days post-surgery, if your bowels are still not opened, if you're a cystectomy patient, we will think of giving you suppositories. Day 4, we'll give you an enema if your bowels does not work. And day 5, we get a bit more inventive, and we will look at giving the patient either erythromycin IV to try and encourage bowels, obviously cause side effect of diarrhea for the erythromycin, or to give them gastrografin, which has a twofold effect. It will side effect of diarrhea, but what it will help for is we can then send it for x-ray and see whether or not there's a blockage in the gut or whether or not it's just a paralytic ileus. The patient will be aware that if they develop a paralytic ileus, that they may need an nasogastric tube. With the cystectomy patients, it's also very important when they start eating, they are on sips of clear fluid the day of surgery afterwards. They will then slowly build up to free fluids over the next few days. It's very important that you follow the instructions that's daily given by the consultant. If you feed these patients too early, their likelihood of developing an ileus is much increased compared to trying to follow the guidance and slowly building them up. When they do start eating, they will have something called a light diet or low fiber diet. The patient will, when they see us in pre-op, actually be given a leaflet that says light diet, low fiber. And it gives them food that's good to eat and foods to avoid. The reason they avoid those foods is the gut can't cope with the high fiber content post-surgery, and the high fiber content will also cause them to have quite a lot of abdominal discomfort. The other thing, obviously, this patient has altered body image. We have changed something drastically about them. We've removed their bladder. If they're male, we've in all likelihood removed their prostate. We've removed lymph nodes in the groin. If it's a female, we've done a full hysterectomy and also removed the top of the vagina. So this has impacts on how they will view themselves in future. So please be mindful of that as you see patients. If they are struggling, please make the specialist nurses aware of that so that we can provide support for those patients. The stoma nurses would have seen the patient prior to surgery and sighted them. They will then wake up post-surgery with their stoma, with bag covering the stoma. They will be taught how to look after the stoma bag. So it's important that on a daily basis you help this patient to change their stoma bag. Stoma nurses only works Monday to Friday in all likelihood. So please look at their plan for the weekend so you can help the patient. It's a good idea to involve the family in looking after the stoma bags. If it's a new bladder patient or a Mitrofanov patient, they will have catheters in. You need to teach them how to look after their catheter, and you need to get them involved with flushing their catheter. In the protocol, there's clear guidance as to how many times the catheter needs to be flushed and how washouts needs to be performed and when it needs to not be performed. If at any time the patient's catheter stops draining and you cannot get it unstuck, it's important that you get medical help early. A new bladder or an augmented bladder with a Mitrofanov on it cannot cope with the pressure of a full bladder, and you can actually cause it to rupture. So early assistance is needed. The other thing to be aware of, all the patients who's had their ureters removed or cut off when their bladder was removed will have stents in, because anastomosis between the new bladder or the stoma where the ureter plants in needs to heal as a pipe rather than shut. So the stent stays there for about 10 days. They're usually a little green or blue tube and a pink tube, and this is just to engage to the surgeon whether or not it's the left or the right ureter, and the urine will in all likelihood for the first few weeks drain via that. So normally the stents will stay for about 10 days. If it's a stoma patient, we will bring them back to hospital, or they can be seen locally and the stents will be removed. They do not require any anaesthetic for removal. It's just slow removal, slight discomfort in the kidney, and you have to warn the patient that they may develop a pyrexia, so in other words, a kidney infection with a high temperature where they would need antibiotics for. The other thing to remember of the new bladder patients, their stents will be attached to their catheter. So when they come back for their cystogram between 2 and 6 weeks post-procedure, they will come to the outpatient department where we will remove the catheter. When we remove the catheter, because the stent is attached to it, we will pull the whole lot out. But we will explain that to the patient when we see them at that stage. When patients go home, it doesn't matter which of the urology procedures they've had, they will go home with Clexane, which they'll do for 28 days. They'll go home with anti-embolized stockings, and these are all to try and prevent blood clots from forming. We will also ask them to do their breathing exercise and continue that till they're fully mobile at home. And the reason for that is obviously we don't want them to end up with chest infections post-procedure. But we have got a discharge page in the back of the protocol that will give you a bit more guidance if you're unsure as to what information that patient needs to go home with. It's a good idea that if you're unsure to speak to one of the specialist nurses, because we will try and guide you through what to do and how to safely get those patients home. We phone these patients post-procedure, and we have a traffic light system where we'll actually assess how well they're doing. And depending on what they score will depend on what we'll advise them to do. If they're doing well, we'll just phone them in a couple of days again, see how they're doing, and leave it at that. If they score a few warning signs, we may phone them the next day to check and see if it's improved. Or if they score things that we feel that they're at risk, we will actually speak to the consultant of that patient, the on-call consultant, or we'll get them reviewed in the local A&E or in the hot clinic. Because the patients are out of area, it's not always possible to bring them back here, but the local A&E can help and support us with that to make sure that patient is safe. This is major surgery. The patient can become very unwell very quickly, and that's why it's important that we stress to them when they go home and on their discharge letter that if there's a problem, and we will list the problems, that they need to seek medical help and not wait for us to phone them in a couple of days' time when it could be too late to then support them.
Just also be aware there's a few other surgeries which we would use in nurse recovery principles, such as adrenalectomies, where a tumour is removed from the adrenal gland, patients had laparoscopic lymph node dissection, or patients that have had sarcomas, excisions. All of these abdominal surgeries would use the same principles as already described.